All right. Where I think we left off last week was the 4 causes of hypoxemia. Is that correct? All right. All right. The 4 causes of hypoxemia is something you have to make sure that you understand. Hypoxemia, remember the definition of that is not desaturation, but it's actually a drop in PaO2. Okay? And if your PaO2 is high, because that individual is on high FiO2s, you may not normally see it unless you draw blood gas. So hypoxemia is a indicated change based on a blood gas determination. If you go from a PaO2 of 600 and you drop down to 200, that person is becoming hypoxemic. Okay? Even though you would not see it at all on your pulse oximetry. Your pulse oximetry would still show that the person is 100% saturated on that high FiO2 of 1. Okay? So make sure that you understand the wording. I think the books don't really explain that hard enough, and I think this is like the 3rd time I reiterated it because I think it's really, really important, the differentiation. So the 4 main causes of hypoxemia is hypoventilation, diffusion impairment, shunt, and ventilation perfusion inequality. By far, what we see the most in the operating room is mostly hypoventilation because of the medications that we give. Okay? But in reality, in the clinical setting, if somebody asks you on a board certification exam, they ask you which one is the most common, the answer is ventilation perfusion inequality, which is the 4th one. Okay, that's the most common. And that because it's, if you come in with pneumonia, ARDS, which are the more common diseases, not really hypoventilation, then those patients will have that kind of disturbance. Okay? So let's go at hypoventilation first. Okay? Hypoventilation is an inadequate ventilation taking place at the alveolar level. Okay? That person could still be ventilating, but it could be just dead space ventilation. And one of the things that I might want to make sure that you understand about is when you talk about this to different professors, you're going to get different answers. And I'm going to give you an explanation as to why you would get different answers. Normally, when you have true hypoventilation, where you have a decrease in alveolar ventilation and an increase of what's called dead space ventilation, your end tidal CO2 will actually drop. Okay? And that's kind of confusing for students. Other times professors will tell you, well, no, end tidal CO2 rises. And so what's the discrepancy? The other professor's wrong? No. It depends on the question and how it's being asked. So let's look at a little diagram here that I'm going to give you. And do dead space first, and then we'll do a little bit of alveolar ventilation here. Okay. The size difference for this is 2/3 versus 1/3. So this is dead space, and this is alveolar ventilation. Okay? And eventually you have your endotracheal tube up here where you have your measurement of your end tidal CO2. Correct? Okay. If I were to ventilate you normally, okay, and basically push air all the way down to the alveoli, the gas that we use to monitor the degree of ventilation or effectiveness of ventilation is really CO2. So carbon dioxide is really the gas that we are really using to monitor effectiveness of ventilation. The problem with that is that usually it's a blood gas measurement. Okay? And if we look at CO2 values, it should be around 40 in your blood gas. But in the operating room, we want to have sort of a continuous monitor that indicates the degree of ventilation to perfusion ratio and also the degree of how well you're ventilating. Okay? If you're truly effectively ventilating well, okay, the difference between the arterial blood gas CO2, which is 40, and the end tidal CO2 is around 4 to 5. Some books will say 2 to 5, which is fine. So most people, though, live about 36 to 35. So if their blood over here, the CO2 is 40, then my end tidal CO2 over here is going to be 36 to 35. Okay. Why the drop? And the answer is because there is no CO2 leaving via the tracheal mucosa. Okay, so in other words, all the dead space is dilutional volume. there is no CO2. Once the gas gets pushed in, there is no CO2 left in the trachea. When the person exhales again, then that has to dilute out the CO2 that's coming out of the alveoli, and as a consequence drops the end-tidal CO2 from 40, which is what's in the alveoli, down to 36 to 35, which is at the measurement, which is your end-tidal CO2 at the endotracheal tube. Okay. Does that make sense? Anybody get lost? Okay. Now, here's a really important part. This is a ratio description. Okay? In other words, it's actually got three parts to this ratio. It's got perfusion ventilation, okay, alveolar ventilation, and dead space ventilation. Now I'm going to show you two different forms of hypoventilation. One is going to actually give you an increase in end-tidal CO2, and the other one is going to give you a decrease in end-tidal CO2. But they're still both hypoventilation. Okay? Now how could that work? Because hypoventilation is an equation based on minute ventilation. Minute ventilation is respiratory rate times tidal volume. Whatever causes a decrease in minute ventilation, it will lead to an increase in PCO2. Make sense, right? So anytime you truly hypoventilate, it doesn't matter what the cause of it is, you're going to see a rise in arterial CO2. Now let's look at your measurement at the end-tidals. How do you know which one you have? And how can it be different for somebody to develop an elevation in end-tidal CO2 that's hyperventilating, but another patient that has a decrease in end-tidal CO2 and they're also hyperventilating? Well, let me answer this carefully. The way you look at this is that you have to look at the dead space to alveolar ratio. Okay? If this individual, let's say, is breathing really deeply, okay, and let's say I give this guy a narcotic, okay, I give him morphine, and because it's a water-soluble agent, I wasn't paying attention to it enough because I got kind of diverted and went away because I gave the guy a considerable dose. Let's say I gave him 15, 20 milligrams IV. The guy was doing fine, he was breathing fine, but then I walked away, not realizing that it takes about 15 to 30 minutes to load. Okay? So at 30 minutes, this person is now breathing 4 times a minute. But when you do narcotic breathing, what happens is you increase your tidal volume, but then you don't breathe for another 20 seconds. So your effective minute ventilation is dropping tremendously, even though your tidal volume is actually increased. Okay, so what's happening to this guy's bloodstream? His CO2 in his bloodstream is rising. Okay? Because he's maintaining the alveolar to dead space ratio by taking these big deep breaths, his end-tidal CO2 will also reflect an increase in CO2, in end-tidal CO2. So as this guy is at 52 on the on the blood gas CO2, his end-tidal CO2 will be like 48 to 47. Make sense? Now let's do something different. Let's induce this guy to breathe really shallow and not fast. In other words, let's give him a little bit of pulmonary edema, okay, wet his lungs down, and now he's not really breathing fast because we gave him an additional narcotic. So even though he wants to breathe deeper, he can't because the lung is just not able to expand properly. He's got lower compliance. So now instead of his tidal volume being like 600, he's down to 100. And his respiratory rate is maybe 10 or 11. Okay? What will you see in that situation is that your minute ventilation is dropping, so your blood gas, CO2, is rising. But your end-tidal CO2 is now going to drop. Here's why. I'm going to take this alveolar volume and reduce it like this. So now, instead of this 1/3 to 2/3 ratio, I'm going to have 1/2 is dead space, and 1/2 of my ventilation is actual alveolar. So what's going to happen to the CO2 as it comes out into the trachea? It's going to dilute even more. the volume ratio dilutes the actual CO2 tremendously. And if you drop alveolar ventilation even more dramatically, okay, like where you're down to 1/3 and 2/3 is dead space, then you'll have end-tidal CO2s in the 15 to 20 range, and you're wondering, like, why is this happening? Why is the CO2 on the end-tidal dropping, but my blood gas is rising like crazy? Okay, it's because this ratio inside the lung, you're really moving only dead space gas. You're really not moving alveolar ventilation. Okay, this happens pretty often, believe it or not, in laparoscopic procedures. Okay, if you take a patient and you flip them upside down, their effective FRC significantly reduces. And then all of a sudden you start seeing your end-tidal CO2 drop, which should not make any sense. Your blood pressure is holding steady, and you didn't change your ventilation at all. And why is the CO2 falling? And the answer is you're increasing the dead space ratio compared to your alveolar ventilation. If you see that, you need to do something, because pretty soon after that, you're going to start following with desaturation, or at least hypoxemia will start setting in. Okay, does that make sense? Did I lose anybody? Okay, so when people ask you that question, you got to sort of ask, is that person taking a deep breath, or are they taking a shallow breath? If it's shallow breathing that you're talking about, then end-tidal CO2 falls in that situation. If the person is taking big deep breaths but still has a decreased ventilation, then the end-tidal CO2 will rise with that hyperventilation. Okay. All right. Now, so under normal circumstances, when you see inadequate alveolar ventilation, is that the alveolar oxygen levels will begin to drop. Okay? So as a consequence, the arterial PaO2 will fall as well. Okay, so hypoventilation very often sets up a hypoxemic event. Now, can you mask it easily? The answer is yes. Hypoventilation can be very easily treated, at least hypoxemia can be very easily treated with additional FiO2 and mask the problem. On the other hand, CO2 is not. CO2 cannot be changed by increasing FiO2. So even though the person appears to be adequately oxygenating or saturating at the time, you can actually have a significant increase in arterial CO2 levels, which leads to a metabolic acidosis and eventually to cause CO2 narcosis in that individual. Okay, eventually, if your VQ, your dead space to ventilation ratio is off, you'll see the decrease in end-tidal CO2. That's the eventual, what you will cause, is a eventual decrease in end-tidal CO2 most of the time. Now, what causes hyperventilation is something that you need to know, and you have to go from brain down. Okay, so walk it through. Anything that affects the brain can cause the medullary respiratory drive to be depressed. So, patient who's got intracranial hemorrhage, somebody who's got over-narcotized, who has been given induction agents of anesthesia, which are barbiturates or benzodiazepines if you give too much of it. Okay, a spinal cord injury can also cause this. Patients that have had a high spinal, okay, that can do this. Then the next area is the nerves that are coming out. Okay, so you can get phrenic nerve damage. Okay, you can get interscaling block inappropriately knocking out one of the phrenic nerves or both sides, and you're going to knock out both lungs, which is a bad form. You shouldn't do that. You can have impaired muscle workload from either the diaphragm fatiguing, or it could be from the person getting neuromuscular blockers, or getting somebody Botox poisoning. That can cause a problem pretty significantly, pretty quickly. And any kind of disease that attacks the muscle itself, you can have different kinds of what's called, what's the name of it? Mitochondrial diseases that basically cause destruction of the ATP production in the muscle cells. There's lots of weird stuff that can happen too that makes the muscles not work, which will lead to hypoventilation. You can also, of course, have Guillain-Barré, which is a nerve damage causing ascending paralysis, and you can have things like myasthenia gravis, but also will affect neuromuscular transmission. Hypoventilation can also be caused by chest trauma, where you actually have fractured ribs or contused lung, or high resistance to breathing from very dense gases or great depth underwater, which gives you like a restrictive disease in essence. If a boa constrictor wraps around you, that's considered hypoventilation. Okay? Because what he's going to do is he's going to keep squeezing you so you can no longer take in a breath. So you effectively are hypoventilating. And what puts you down is not the oxygen levels usually, it's that you become hypercarbic. So it takes a long time for you to go down. Okay? Especially for men, I've seen it takes about 15 minutes to go out when if a boa is constricting you. And an animal, it goes faster. Why? If you wrap a mouse, and the mouse goes out within about 2 minutes. Right, their metabolic rate's so much higher, so they're producing a lot more CO2. And their oxygen consumption rate's like twice ours or 3 times ours. So they don't last very long. Okay, so not very effective in bigger animals. Which is why you see most likely that there's not big constrictors out there, not taking down something big like something really big like an elephant or something. There's never going to be a constrictor that big, I don't think. Elephants' breathing rate's like 4 breaths per minute. The boa would be waiting a long time to squeeze him. So, damn, what's wrong with this guy? Doesn't he breathe? Okay, versus we breathe a little faster. But a mouse breathes really fast. He's breathing about 40 times, 50 times a minute. So every time he breathes, he gets squeezed. Okay? So diffusion, okay, is the next problem. Diffusion is a lot more rare. What you see is basically an inability for the gas to transfer through the alveoli into the capillary system, and which usually indicates to you that there's something wrong with the alveolar membrane wall. Okay? Things that will cause problems with this will be, of course, things like pulmonary edema would be an example of this. ARDS would be another example of a diffusion impairment. You can get exposure to certain chemicals that can cause the lungs to white out on you or get wet, which will cause a diffusion impairment. Okay? What you see on these individuals is that the AA gradient becomes greater, which means that the alveolar expected concentration to the arterial expected concentration are getting wider. Okay? And if you're at rest, you're not going to really pick it up, but if you try to exercise this person or move them around, you're going to pick it up a lot faster. Okay? Also, if you go up in altitude, it's going to be much more noticeable. The patient has a blood gas barrier that's thickened, and if you have a low oxygen mixture is inhaled, you get a decreased concentration gradient, and the AA gradient becomes very much more significant in that situation. The next one is shunt. Okay, now this one is diffusion is easily responsive to oxygen as well. So in other words, if I increase the gradient, I can many times overcome a diffusion impairment problem. So sometimes what we do is, when we're in a case, is we'll draw blood gas, and we'll see that the blood gas PaO2 is low. Let's say it's like 85. And then we'll do an oxygen challenge test. We'll bump up the FiO2 to, let's say, 100%. Some people don't do it that much, but we can go to 100%. And then you get your next blood gas value, and it goes up from 80, and all of a sudden it goes up to 400. Well, that's hypoventilation, or it could be diffusion impairment. Okay, you can't differentiate the two. The one that is definitely not going to be that big change is shunt. When you get your blood gas value comes back, it's going to come back like 100, 110, and that's it. So only a 20 millimeter change in oxygen levels, versus if you gave it to diffusion or hypoventilation or VQ inequality, you would jump up by 200 to 300 points. And that's what we call non-oxygen responsive. Okay? So that would tell you that it's shunt. Shunt happens in the operating room very frequently because we put endotracheal tubes in patients. And you can still hide shunt from desaturation, because if I give you 100% FiO2 and your saturation goes from 94% to 100%, does it really mean that you're oxygen responsive? The answer is no, because I could have gone from PaO2, let's say, of 65, that all of a sudden it jumps up to 85 to 90, okay, and now that person's 100% saturated. But you only jumped up by 30 points. That's not really oxygen is considered sensitive. But it fools you because you're watching, instead of hypoxemia, which is blood gas values, you're watching your pulse oximetry. Now, What shunt basically is telling you is the degree of blood that's going through the lung without being effectively ventilated. Okay? There's two kinds of shunt, and I'm not going to dwell on this a lot because otherwise you guys are going to go crazy. There's two kinds. There's physiologic shunt and there's respiratory shunt. What I concentrate on in this coursework is respiratory shunt. So don't go into a physiologic shunt and tell me, well, that's a significant value. The answer is it's mostly insignificant. It's around 2 to 3% most of the time. Physiologic shunt can jump up to as much as 5% or 6%. That's, unless you have a VSD, then it can become very big cardiac shunting taking place, which is really not considered physiologic. Physiologic shunt means that blood goes through areas that are normally going to be there available for most of us. Okay, that's considered physiologic shunt. The most common physiologic shunt in your heart is the basin veins. Okay, it's a system set up in your heart so in case PA pressures rise rapidly that it can divert blood through the ventricle itself. So you take some of the load off the ventricle. Is that really significant? 5%? I don't think so. But if you put a big hole in the heart, like a VSD or an ASD, that's not really physiologic shunting anymore. I consider that cardiac shunting, which is completely different. Now, when we talk about respiratory, which is what we're talking right now, we're talking about respiratory shunt, which means that blood is going into the lung, but it is no longer being ventilated. Okay, so that's what we're talking about here today. Okay? If I were to give you an example of physiologic, what respiratory shunt is main stem intubation. We main stem intubate people all the time, unfortunately. Not because we're not paying attention, it's just because some people have shorter tracheas. Sometimes people will be positioned differently and the lung will get pushed up and it will cause the endotracheal tube to main stem. Okay? And when you main stem, the most common site you're going to main stem is the right bronchial. Okay? So you're going to knock out the left lung completely in the process. When you do that, it's going to cause a 40% respiratory shunt. That's pretty impressive if you think about it. That's a big, big value because 40% of your cardiac output from the right ventricle is going to the left and 60% is going to the right. Okay, so when you main stem, that means all the blood flow that's going to the left is basically going to an empty, non-ventilated lung. Okay, and that's considered shunt. Okay, does that make sense? Now, shunt is not really responsive to oxygen therapy. What you're looking at is, these are normal shunt. This is abnormal shunt, which is pulmonary venous shunts, ASDs, VSDs, obstruction of bronchioles, and atelectasis. Okay? Now, that being said, respiratory shunting that we encounter very often can be due to main stem. The other one that I want you to think about is atelectasis. Atelectasis is basically collapsing the lower portion of the lung to the point that the alveoli do no longer accept air from the mouth. Okay? Why does that happen? Well, your diaphragm is a very important muscle that normally maintains an absolute constant information feedback to maintain its tone. That tone is what maintains your FRC, which is your functional residual capacity. That's the point where your lung is going to stay as much inflated as it can before the diaphragm begins to drive down and cause inflation to take place. Now, what you should understand is that anytime you give anesthesia, it doesn't matter which kind, you've used muscle relaxant, non-muscle relaxant, an induction agent, anything that puts somebody to sleep, what we have found is that we suppress the feedback mechanism of the diaphragm. Okay, that feedback mechanism then makes the diaphragm become less efficient and loses around 20% of its FRC. So it doesn't matter which way you do it. If you use Versed, Diprivan, etomidate, ketamine, it doesn't matter which agent you use. If you suppress somebody to the point where they're unconscious, you're going to have a 20% reduction in FRC in every time. So people can tell you, well, I like using an LMA because I don't get as much FRC decrease. Nonsense. Lies. Total lies. Okay? It doesn't happen. Okay? Every patient that you have that you put to sleep is going to have a reduction in FRC. If you want to do a spinal anesthetic, okay, and you want to sort of avoid this problem, and that's fine. If you want to stay below T6, I'm okay with that. But then don't come back and tell me, well, you know, Dr. Nolan, we were doing this guy a great job, and then we gave him Versed. You just lost all the benefits of the spinal, okay? Because the Versed now just inhibited the diaphragm from working properly, just a little bit, okay? And if you really are doing what we normally do, which is we take Diprovan and run it during the case to keep the person from hearing the hammering, because nothing worse than having a patient hearing somebody clanking on their leg with a big hammer. You ever been in an orthopedic room? How many people have been in orthopedics? Almost everybody, good. So who has not been in an orthopedic room? Okay, you're in for a charming event, okay? The first thing you'll notice is, especially, my wife calls me every once in a while when I'm doing stuff, and you hear, she's going, what the hell are you doing over there? You in a carpenter shop? Yep. It's called an orthopedic carpentry shop. Okay? So the equipment is very noisy, and people are hammering on your leg. So you can actually feel your hip moving up. Even though it doesn't hurt, you still feel the hip being pounded on. Okay? So is that really a wonderful, pleasant experience for most people? I mean, everybody says Disney ride. Hey, let me do that again. You know? Most people are going to say to you, I don't want to remember anything. I don't want to hear it. I don't want to do anything. Okay? So a lot of times when we do all these spinals and epidurals, we end up sedating people with Diprovan. And if somebody comes back and tells you, well, we're doing this and we're effectively not going to have as much respiratory compromise as a person who's under general anesthesia, I'm just telling you that they're wrong. Okay? They're absolutely wrong. All the studies show that as soon as you start sedating people and put them in an unconscious state, you just lost 20% FRC. It is irrelevant how you do it. Okay, so if you're really worried about somebody's respiratory drive, what must you do? Or somebody's lungs, if they're really marginal, put a spinal in, flip them on their side, or do whatever you need to do, and then talk to them. And that's it. That's all you can do if you want to have no effect on the lung. And hope that it doesn't get above T4. Because once it gets above T4, guess what you start losing? You start losing the muscles that hold up your lungs, which then drops your FRC, and you get in the same situation. Kind of a tight bind. Okay? The other day, I had to do a spinal on a girl that was 16 weeks pregnant. Okay? And you know, everybody says, "Oh, well, you know, it's the right thing to do." And I'm going like, "Yeah, it's the right thing to do, but watch what's going to happen," because invariably it always goes wrong. Okay? We did everything perfect. We had a T8 spinal, perfect spinal, doing a stent. Okay? And as soon as we put her in the room, her blood pressure went from 140 to 115. Now, 115, that's horrible, right? It's not bad for me, it's not bad for you, but of course her was symptomatic and she started hurling. Okay, so she puked for the rest of the 15 minutes of the case. Now, is it a bad thing? No, she did fine, the baby did fine. Baby had zero exposure to an anesthetic, so the baby was very happy not being messed with. Okay? But you know, people tell you, well, there's no risk to anything. No, there's risk in everything. Anesthesia is not a perfect science. It never will be. You better be prepared for anything that goes wrong. Okay? So I had to sit there and talk to her the whole time, which is fine. We talked to her. What can you not give to a woman who's pregnant? You can't give her Versed. Versed is a class C drug that affects the baby's development. So now you have nothing to sedate her with. And you can't because she's vomiting too. So she's going to have to recall the whole thing. The cool thing about it was, actually when we were finished, she looked at us and says, she wanted to see the ultrasound of the baby, so we showed the baby ultrasound. And then we did the heart rate, and then she heard the heart rate was 156, and she goes, okay. Everything else, I was sick for a little bit, I was fine. The baby's okay. And you can see the mental, right away, that took away all that nonsense. So always know where your endpoint's going to be. Know also when you're doing things that invariably things are going to go wrong. Okay? And shunt's one of those things. No matter what you do, you're going to have a drop in FRC. In other words, shunt fraction is going to increase when you put some people under anesthesia. What is the lowest FiO2 that we set patients at in the operating room? Do you know? What does the anesthesia machine start alarming at when the FiO2 falls below that? 30%. You should have all your anesthesia machines at 30%, which means that you should be delivering at least 30% oxygen to all your patients. But you have to ask yourself, well, why magically 30%? Why not just use 21%? People live on 21% all day long, right? Because of this. shunt. The shunt, as soon as you go up, you're going to get a 15% shunt increase. Period. Boom, just like that, as soon as you put somebody to sleep. So the higher FiO2 will help overcome a certain degree of the shunt that you're going to encounter. Okay? Does that make sense? Because the atelectasis is never going to go away. It's just something that's going to be commonly seen under anesthesia. There's nothing you can do to prevent the atelectasis. Nothing. There's no form of ventilatory management that can change your atelectasis rate. Now, what may coming down the road may be that we might be cerebrally put people to sleep and maintain the main stem completely intact. But that's science fiction right now. Okay? But there's a possibility that we could actually inject or put into the person's brain electrical waves to disrupt the cortex, and at that point the person would be asleep, but their brainstem would still be functional. I have to see how many people want to volunteer for that anesthetic yet, but we'll wait and see on that one. Okay, but that's still maybe 50, 100 years down the road right now. But for now, when we give drugs to patients and we inhibit the whole portion of the brain, you're going to knock down the brainstem, you are going to see a 20% reduction in FRC no matter what you do. Now, important features of shunt is the hypoxemia responds poorly to added inspired oxygen. When 100% oxygen is inspired, the arterial PO2 does not rise to the expected levels, okay? And that's, I hate when the book says that, but never explains what that really means. After I've explained to you just now, I hope that you understand the differences in PaO2 and saturation. Okay? If shunt is caused by a mixed venous shunt, its size can be calculated from the shunt equation, which is what this is. I personally don't use this. Okay? It's too cumbersome. Instead, we have nomograms, which I'll show you in a respiratory pathophysiology next semester. The nomograms I carry in my pocket. Now I actually put it in my iPad. So whenever I run into a shunt, I can just go across, go FiO2, where's my PaO2, boom, and then it tells me exactly the amount of percentage shunt. That's it. Okay, that's a nomogram. Easy visual thing. Okay, if you want to do the math, then you have to do all this calculation, which is a little bit more involved. You have to know cardiac output and all this other stuff, which is not something that necessarily is easy to do. That's why the nomograms become very useful. Normally, CO2 does not result, even though shunt can be significant, CO2 doesn't usually rise. If the person is ventilating on their own, as the shunt increases, CO2 will start to rise, but the respiratory drive will make the person increase in minute ventilation. Now, does that really apply to anesthesia? Heck no. The person's asleep and paralyzed. So when you get shunt, what happens to CO2? It starts going up unless you increase minute ventilation, which most of us were not going to realize. Okay, so just be aware of that. Okay, this is your shunt equation. I'm not going to make you memorize. Please do not memorize it. I do not memorize this in my own head, so I don't expect you to memorize it as well. Okay. Then the last one is ventilation perfusion ratio. Ventilation perfusion ratio is the most common cause of hypoxemia, and I think this is kind of a garbage term because it's a mixture of shunt and dead space. So it's really a combined both effects at once. Okay. And sometimes you'll figure out that this person has more shunt, this one has more dead space, and it's kind of hard to figure out sometimes. What you see is that ventilation perfusion ratio, the optimal level is to match. For every 1 part of air that goes in, you should have 1 part of blood going by, which is at VQ of 1. Okay? In human lungs, the VQ is around 0.8. So in other words, for every 0.8 parts of ventilation, we get 1 part perfusion. Okay? In other words, that means that your lung is more perfused than ventilated. Just think of it that way. Okay? It's by 20% less ventilated than it is perfused. Okay? Now, what can actually affect the ventilation perfusion ratio is you can go one extreme to the other. If you go to shunt, okay, you're basically moving to the portion where you have no ventilation and you have only blood. Okay, so it's 0 over 1, which means that you're going towards 0. Okay, that's just the number you're reaching. On the other hand, if you're going towards dead space, okay, which is another part of the VQ inequality, means that you have decreasing levels of perfusion. And as a consequence, ventilation stays fixed at 1, let's say, and then your value underneath is becoming less and less and less. If you're going to 0.01, that would be 10. If you go at 0.0000000, whatever else it is, it's approaching very high numbers, millions, trillions, whatever you keep going. Whatever you think of next will be the next value. Okay? So you're basically reaching for infinity. That's what they come up with. Okay? I've never understood the concept of infinity. I still do not understand the concept of infinity because it's a value that doesn't have a never-ending point. So instead I use the denominator underneath becoming less and less, which I can understand mathematically. So what you see in these different situations is there's different BQ ratios, okay, which will cause differences in your blood gas values in that individual. Under normal circumstances, you're at point A, your normal PaO2 is around 100. This is for room air at sea level with a FiO2 of 21%. Okay? If that person is reaching towards dead space, what you end up having is at the alveolar level here, okay, you're reaching your maximal alveolar oxygen level, which is 150, but your CO2 will go to 0. Okay, so in dead space, the alveolar concentration, what's inside the alveoli, will have the maximum amount of oxygen, but have the least amount of CO2. Which part of the lung has that situation? The apex of the lungs, at the top of the lungs, which is where TB lives. Tuberculosis is not an anaerobic organism, it's an aerobic organism. It loves oxygen. Okay, so if I'm going to be sitting somewhere in somebody's alveoli, I want to sit on the top of his lungs where he's got the most amount of oxygen and I'm in a real oxygen-rich environment. On the other hand, TB is almost never found at the base. The reason it's not found at the base is because when you go further down, there's more degree of shunt fraction as you go towards the bottom of the lung, which means that you're going to an area that's perfused, but the lung begins to collapse or develop atelectasis of that portion. Okay, so in this area, the alveoli has a equilibration between the alveoli and the blood. So the PaCO2 is the same as the venous side of it, which is like 45, and your PaO2 is basically the same value that comes back from your venous blood, which is around 50. Okay, so that's where you live. Okay. Now the regional gas exchange ratio here is to show you that blood flow is still greater at the bottom of the lungs in comparison to ventilation, which accounts for that BQ ratio of 0.8. Right around the rib 3 is where the BQ is 1. If you throw somebody into space, the BQ is actually 1 almost immediately because perfusion now equilibrates across the whole lung, and so does ventilation. So if you're an astronaut in space, your VQ ratio is actually better than it is on the planet. Okay? Now, if you look at regional gas exchange in the lung, blood flow is greater at the bottom of the lung than ventilation, so areas more like shunt. Okay? VQ is approaching towards 0. As you go down the lung, PaO2, which is alveolar oxygen, decreases. And as you go down the lung, your P alveolar CO2 actually is increasing, which leads to a decrease in pH in that area as well. If you look at the other on the top of the lung, ventilation is better than blood flow. So you go up the lung, your PaO2 increases, which is, remember, this is a big alveolar O2. And then as you go up the lung, your PaCO2 is decreasing tremendously, and the consequence leads to a pH increase. This is the ratio area to the lung, showing you the base of the lung is down here, okay, and then you have the apex of the lung would be the top up here. And this is another way of looking at it. The effect of ventilation perfusion inequality on overall gas exchange is that perfect VQ will lead to a higher level of PaO2, okay, which is the arterial O2. Remember, the maximum you can really reach of arterial PO2 will be at your maximal point of alveolar ventilation, okay, which in this case is around 100 for the example we just said. So the maximum PaO2 you can be in that situation would be 100. And a decreased level of PaCO2 is what you end up seeing, to around 40. And normal VQ will lead to a decrease in PaO2 every time. Now, you may not always see a change in CO2 because most of the time what happens is your brain senses that drop much more aggressively than the PaO2 changes. So most of the time the respiratory drive center will increase ventilation or decrease it to maintain a normal CO2 level. Now, so do you see ventilation perfusion inequality as a cause of CO2 retention? And the answer is it can, but it's very unlikely. Okay? The ventilation-perfusion ratio determines gas exchange in any single lung unit. And regional differences, an upright lung causes a pattern of regional gas exchange, which we talked about just a few minutes ago in that picture. And the VNQ inequality impairs the uptake or elimination of all gases. Okay, so PaO2 decreases, and PaCO2 would increase unless an increase in ventilation. But most of the time, like I said before in the last statement I gave you, was that CO2 is usually maintained because the chemoreceptors are activated, which result in increase in ventilation. And you have an increased level of CO2 levels may actually usually indicate impending respiratory arrest. So if you see that the CO2 is actually rising, it may be a good time to start pulling out your laryngoscope and getting all your suction ready to go and all your endotracheal tubes ready to go, because this person is most likely going to go into respiratory, or what we call ventilatory failure. Okay? By contrast, hypoxemia resulting from VQ inequality cannot be eliminated by increases in ventilation. Okay? So only way to sort of eliminate that problem is to add more oxygen. So people that have VQ inequality can be treated if they're developing oxygenation failure. Giving them oxygen will relieve a certain degree of symptoms that you see. And the last thing is the dissociation curves for the different gases. O2 and CO2 have completely different dissociation curves. Okay, and because of that, they act differently. CO2 curve is actually very linear or almost straight. So if you increase ventilation, it will result in a decrease in PCO2 very rapidly, versus the oxygen dissociation curve is almost flat. So even though if the person begins to hyperventilate, you cannot see that big change in the PaO2 because they've already flattened out. So you really don't get any benefit from that in comparison to CO2.